Hello and welcome to today's Better Care Playbook webinar, made possible through the Seven Foundation Collaborative on making the value case for complex care. Before we get started, I'd like to quickly go over a few logistics. To eliminate background noise, audio lines are muted during today's event. There will be a moderated question and answer session following today's presentations. You may submit a question online anytime by clicking the Q&A icon located at the bottom of your screen. Instructions are shown on the screen at this time. Today's event will be recorded and shared publicly on bettercareplaybook.org. At the end of the webinar, we ask that you please complete a brief online evaluation that will pop up on your screen. Your feedback is very important to us, and we hope that you'll take a moment to do this. I will now turn the webinar over to Logan Kelly, Senior Program Officer at the Center for Healthcare Strategies.
Thank you so much, Travis, and welcome everybody to today's webinar. We're really excited today to explore ideas for how people in the field of complex care can measure and show the value of complex care programs. Next slide. And then before I walk through the agenda and introduce the presenters, I'll just provide a brief overview of the Better Care Playbook. The Better Care Playbook is an online resource center for evidence-based and promising practices to improve care for people with complex health and social needs. So it provides summaries of recently published evidence-based and promising practices, such as journal articles and reports on topics that cover complex care interventions, health-related social needs, and also financing complex care programs. The playbook is a place to learn about first-person perspectives through case studies and webinars, such as this one that highlight implementation experiences. And the playbook summarizes and links to implementation tools, such as the Making the Value Case Toolkit that is featured on this webinar today. And these tools are really designed to help stakeholders translate that evidence and research into practice. During the webinar, we'll be drawing on some of the resources on the playbook, and we encourage you to go to the playbook for more information and to submit resources based on your own work for potential playbook inclusion. And you can find the playbook at bettercareplaybook.org. Next slide. And the playbook is coordinated by the Center for Healthcare Strategies through support from 7 leading national healthcare foundations: Arnold Ventures, the Commonwealth Fund, the John A. Hartford Foundation, the Milbank Memorial Fund, Peterson Center on Healthcare, the Robert Wood Johnson Foundation, and the SCAN Foundation. Next slide. On today's webinar, we'll hear from different speakers on how program design and partnership with organizational finance leaders can strengthen the value case for complex care programs and generate sustainable financial support for this work. First, Lauren Hardin and Mark Homowicki from Camden Coalition's National Center for Complex Health and Social Needs will share findings from their work and introduce the recently published and really wonderful toolkit on making the value case. Next, Susan Cooper and Rick Wagers from Regional One Health will describe how partnerships between clinical and financial leaders can create a compelling business case for financing complex care. And then we'll have a moderated dialogue between 2 CEOs, Paul Leone of the Illumination Foundation and Rebecca Ramsey of Housecall Providers, on their experience and insights on partnering with payers and sustaining programs. And finally, our presenters will answer questions submitted by all of you during today's webinar. So again, if you have a question you would like our presenters to answer, please submit it anytime by clicking on the Q&A icon located at the bottom of your screen. Next slide. And as you can see here, we have a really wonderful lineup of speakers today, and I'll introduce each one before their respective presentation. Next slide. And now I will turn it over to our first presenters. We are fortunate to be joined by Lauren Hardin, who is the Senior Advisor at the National Center for Complex Health and Needs, an initiative of Camden Coalition of Healthcare Providers, and by Mark Homowicki, the Senior Director with the National Center. Lauren and Mark, welcome, and I will turn it over to you.
Thank you so much, Logan.
Thanks, Logan. Next slide. I want to just start by thanking the Commonwealth Fund for their financial support and thought partnership on this project. This project dates back more than 2 years. We were actually launching it pre-pandemic, and the impetus was that we had seen many complex care programs developed with grant funding or pilots with payers, but after a year or 2, clinical leaders struggled with translating their important work with patients and community partners into a financial language that would generate sustainable financial support. So our goals in the project were really twofold. One was strategic communications to help financial executive leaders, including payers, to understand the value of complex care programs and make more significant long-term investments in complex care programs. And the second was really about capacity building, helping clinical leaders understand how to translate their work into a value case to garner support from internal stakeholders, community partners, and payers. We partnered with the Center to Advance Palliative Care to adapt a set of tools they had created for their Payment Accelerator program, and actually developed a whole new set of tools and guidance that are part of the toolkit that we'll talk about in a little bit. Then along came COVID, and everything changed. The financial picture became bleaker, the vast health disparities and need for partnership with CBOs and public health to address disparities became even clearer. So we actually had to redo some of our interviews and refine those messages. And so what you see today really reflects sort of the best combination of pre and within COVID work, and is applicable to work going forward. I'm gonna pass it over to Lauren to talk about some of the specific findings from more than 100 interviews that were done as part of this project.
Next slide, please. The privilege of interviewing more than 100 leaders across the country, multiple sectors, healthcare, payers, innovators, community-based organizations, national nonprofits, ACO, government, successful complex care programs, and also a deep dive with the CHCS AIM collaborative participants. Throughout those interviews, people were incredibly generous with the lessons they've learned about how to successfully advocate for investment in programs for complex populations. Next slide. A few of the themes that were raised during those interviews include, of course, the challenges that are happening right now from COVID. There's tremendous chaos, a lot of stress and change, very minimal time to take in complex information, and really a desire for easily accessible resources that could be returned to in an asynchronous manner over time. So we built the toolkit to translate those lessons in ways that you can just look at one part of it, click on what you're interested in, and also go deeper into companion resources that will take you even further. Throughout the interviews, regardless of the type of organization or the sophistication and experience of the leaders, similar themes came forward that people wanted addressed, whether you were just starting a program or whether you were adapting an intervention. Really understanding how to target appropriately populations for intervention, really deep understanding of data sources and what kind of metrics are valuable, a deep understanding of what is the variety of payment sources now. How can you report outcomes and really translate the value case in a way where people can understand it and be led to action from it? How can you sustainable financing, and how can you adapt interventions over time to continue to generate buy-in? Next slide.
So this is the cover of our toolkit. We've created both as a downloadable PDF as well as an interactive web version on our website. And the toolkit takes an expansive view of making the business case or the value case, and reminds us that we need to think about what success looks like and how we'll measure that success from the very beginning when we design our programs. We understand that many people in this toolkit already have programs in place and are looking to improve them or to make the value case stronger. There's guidance in the toolkit for them as well. The next slide. The first section of the toolkit is really on choosing your population, using data and clinical judgment to segment populations, understand root causes, and identify a population that you can meaningfully impact their outcomes. We recognize that there's a wide range of access to data and analytics, whether you're working on Excel spreadsheets or you have a whole team devoted to sophisticated data analysis. There's advice and ways of doing this work in the toolkit for everyone. The second section is on understanding stakeholder needs from your internal stakeholders, leadership, partners, payers. All of that is incredibly important. We'll talk about more in this presentation. The third section is on scaffolding populations. This is on understanding and navigating the financial implications of different populations based on their insurance status. The 4 sections on demonstrating value by selecting a balanced scorecard of measures to what we value and how to demonstrate that value. Lauren will show you some examples of this in practice. The 5th section, next slide, is on collaborating with finance. And Susan and Rick are sort of a perfect example of this, the power of this partnership that you'll see later in the webinar. The 6th section gets into application of these strategies to your program, creating financing strategy and budgets, ensuring optimal efficiency of your program. And finally, the last section is on packaging all of this into a value case or an ROI statement that goes beyond just the dollars and cents and makes the full value case to stakeholders for sustainable investment. Next slide.
So we wanted to show you how that could actually look. From all of the interviews and lessons, themes emerged around how to really build a 360-degree view of a value case. And it really is important to think about the different aspects of this as you're thinking about tracking data and really translating the value of what you're doing into a return on investment. Next slide, please. So how this sorted out, definitely equity has risen to top of mind across the country for very important reasons over the last 2 years of the pandemic, and really integrating equity in the measures that you're tracking and also how you're translating the value of what you're doing is really important. Having a really robust demographic data set is important so you can start to understand the impact of what you're doing on diverse populations and where you might want to adjust the delivery. And then looking at certain outcomes as really direct impact on equity, tracking your impact on things like housing or benefits, food security, access to care. And then the AIM project also developed new measures that you could integrate on equity. So really highlighting that as part of your work. Next slide. Then thinking in different quadrants about what you might want to track to translate the value. So we're all pretty familiar with looking at costs and utilization. A lot of times that's the only thing programs are looking at, but you can show a much broader value and impact by integrating other areas. So in the cost impact, starting to think about how are you reducing cost or shifting cost to the appropriate site of care. So an increase in primary care costs might actually be a positive. Looking at utilization again, where are you reducing inappropriate or unnecessary utilization? And where are you increasing utilization that matters? Taking into consideration subtle impact on utilization, like a decrease in length of stay days, has a very strong impact for organizations and can be a very positive advocacy for your program. Then thinking about quality measures. So how are you impacting things like disease management, quality of life, really changes that really matter to people and integrating that in the value equation. Thinking about satisfaction in a 360-degree view. So can you do a client survey around satisfaction? If you can't do a survey, can you do a video or patient stories? The same with providers. How is your program impacting efficiency, quality, satisfaction for providers? And also community partners. How are you creating a more efficient delivery of care and how can you reflect that? And then equity, as I described. Next slide. So what does that actually look like in a value case summary? So this is an analysis of a program, 1 year of outcomes from their population. And the metrics they chose were to look at the reduction in costs for inpatient admissions, a reduction in cost for pharmacy, and they worked with the payer and had total cost of care. So showing that they chose inpatient admissions, ED visits, and length of stay days. In the quality arena, they looked at engaged and completed medication-assisted treatment, Arizona Self-Sufficiency, which is really a matrix to evaluate impact on people's social determinants of health, and then a disease management depression score change. And they also utilized evidence-based measures to look at provider satisfaction, patient satisfaction, and partner. And then they showed the demographics of their population and their impact on equity drivers like housing, benefits, and food security. Next slide. So another important thing to do once you have the data is to really translate what you are, the outcomes you're producing into visualization that people can take in, utilize for advocacy, utilize for funding, and really relationship and partner building. So Adventist Health, we worked with them to create the model Project Restoration, and they have now served 683 patients. They use the value case summary to highlight certain areas of their outcomes. So you can see utilization, cost, you can see improved financial performance, you can see provider satisfaction, and then community linkages as a quality and equity outcome. So thinking about how you translate that visually is important. In the toolkit, there are resources you can utilize to really create a pitch deck or resources like that directly from the toolkit. Next slide. So we wanted to summarize some of the top 3 key insights. There's many things in the toolkit to go deep into, but we'll give you the highlights. Mark, next slide.
Sure. So the first one is about collaborating with stakeholders. Collaboration is a key leadership skill in complex care. The array of stakeholders you need to partner with to be successful is vast, including your own leadership, your teams, payers, and community partners, not to mention patients and their families. To truly partner with folks, you need to spend the time listening and getting to know them to really understand their goals and how you can help them advance their goals while they partner with you to translate your goals and your work into greater investment. This next slide. Another theme coming out of this is just the opportunity to redefine ROI. Typically, ROI is seen as just a pure dollars and cents calculation. But one of the major takeaways from the project and all of the interviews is that even with CFOs, value is defined more broadly than just financial revenue and cost. While those are important considerations and they can't be ignored, there's also considerable value placed on quality, on equity, on the human impact of our work. CFOs are human beings and they work for mission-driven organizations. As you'll hear from Rick, they are motivated by the mission of the work too. So really being able to put together that sort of full picture of value that includes dollars and cents, but goes beyond is critical to success. Next slide.
So building strength and sustainability. This came up over and over, and it's a really important impact area to consider in really successful long-term sustainability. In the toolkit, there are resources and tools for free to help you evaluate how efficient is your delivery. How are you looking at dosing? How are you annually considering how you might want to change your delivery to better meet the needs of stakeholders and the people you serve, as well as the team needs for resiliency and how you're delivering what you're delivering. They're learning to speak many new languages, so really empowering and distributing power with learning the language of finance so that you can translate what you're doing into a stronger case. Starting to look at some of the new codes that are emerging for payment. So renovation and redesign of things like Medicaid. So California, CalAIM, really having new payment for things like housing tenancy supports and care management codes and new opportunities to integrate revenue into complex care is really important. And then developing a very strong way that you annually share the outcomes of your program to build momentum, long-term sustainability, and partnership. Next slide. So what's coming next is a series of blogs and articles in 2022. There's an opportunity to receive individual technical assistance from the National Center into how to individually apply this to your own value case or business case. And then we're also exploring a learning collaborative or course to apply the lessons at another level. I'm excited for you next to hear directly from Susan and Rick from Regional 1, who we've had the opportunity to partner with.
Wonderful. Thank you so much, Lauren and Mark. And I would encourage everyone on the webinar today to check out this interactive toolkit, which is full of insights and concrete downloadable tools. We shared a link in the chat to the page for this resource on the playbook, and that will take you right to this resource on the National Center for Complex Health and Social Needs website. And next slide. Next, I will introduce Susan Cooper and Rick Wagers from Regional One Health. Susan is the Chief Integration Officer and Senior Vice President, and Rick is the Emeritus Executive Vice President and Chief Financial Officer. Welcome, Susan and Rick.
Well, good morning. Next slide, please. I am Rick Wagers, the past CFO at Regional One Health. Regional One Health is located in Memphis, Tennessee. It's the oldest hospital in the state, serves as a safety net or essential hospital for the multi-state region. Tennessee is a non-expansion state for Medicaid. We have an uninsured population that represents in between 24 and 30% of our gross charges, pretty substantial compared to industry averages, and also have a Medicaid population of about 31% of our gross charges. All that being said, Regional One Health is not a wealthy or well financially established health system. So from our perspective, this required new ways of thinking of the uninsured as our largest capitated population, meaning it needed to be managed. Next slide, please. In the beginning, we pulled together a group representing our CEO, myself as the financial officer, Susan Cooper, who is our chief integration officer, as well as our chief development officer over our foundation. Knowing that we didn't have much money to be able to spend and invest, we were making a case of how we could get the foundation and or external funding to help us to tackle this issue. So in doing so, data was paramount to that of drawing and making the case. We framed the opportunity, we built a business case, we sold the case to the funding officials. We then got our senior leadership in our team involved in the care process to buy in. We talked about the need to innovate, that we can't do the same old thing and expect different outcomes. So we had to be willing to challenge the status quo. Next slide, please. One of the keystones to our concept was that every Memphian deserved great health care. And that was paramount to buy in to move this project forward. Next slide. Our goals were to improve the health of our uninsured, medically and socially complex patients, and to bend the financial cost curve for these frequent utilizers. Next slide, please.
Yeah, thanks, Rick. I'll take it from here. So you can imagine having a conversation with the CFO who's really interested in the finances of the organization, and me being a nurse having a conversation around what's good for the individual. And what we learned from our organization is that seeding and growing a program like this takes time. So we put our timeline up here around when we really got serious about development of this program and when we actually received funding, which was in late 2017. And we were very blessed, I think is the right word, to have time to try to think differently about program planning and development, essentially in partnership with the Camden Coalition, using what they had done to jumpstart our thinking around how do we look at the data, how do we bring our community assets together, and what our design ought to look like. And from that, we created our One Health program, which is, as Rick said, a program for the uninsured who are frequent utilizers of the multiple systems of care. I kept saying we could deliver care in a better way and our finances would go down. And Rick, socialized that idea that said, yes, we have to do some things differently. We're not going to go over our program design in this, but I do want to advance to the next slide to talk about our community partnerships. When we're looking at our organization and the lack of resources that existed within the walls of the hospital, we know that we had strong partnerships outside of the walls of the hospital, but many of those organizations also suffered from having modest funding as well. And so our community partnerships and our asset mapping really created this community collaborative of more than 200 organizations. And the one thing that we did have within our organization was a strong grant writing arm. And one of the things that we would do when thinking about the health of individuals, whether it was around housing, food, transportation, was take a look at the make or buy strategy. Was this something that people within the community could do? Did they have the resources to do it? Or could the hospital pay for these programs to be built? And so just from a funding standpoint, as we wrote additional grants to service this population, we would do 100% pass-through to our community partners. Because if you give a hospital something to build, we're going to build a hospital out of it. But we knew that housing experts existed, food experts existed, and we needed to help them help us meet the needs of our enrollees in our program. And if you'll go to the next slide, we wanted to, I'll turn it over to Rick, but we really did some deep thinking and had serious conversations around how did we really think about return on investment? Because traditionally, Rick would use the old CFL model of what we pay and what we get for it. And he has become somewhat of an evangelist for this new way of thinking about complex patients. So Rick?
Thank you, Susan. It's very true that we were lucky enough with the funding to be able to create a pilot and to model, and it didn't take long to develop stories that then created a financial return. And so in essence, we found that we impacted the health and well-being of the participants in our project, created self-sufficiency, self-respect for themselves. At the same time, the utilization of the healthcare institution's resources was dropping, which in turn improved our financial outcomes. And we know that over time, we can see our project participants improving their role in the community, being self-sufficient, being able to provide more for themselves and less dependent upon society. Next slide.
So just to give you some idea of the things that we look at, we have about 47 months worth of data, and this work is done by a very small but dynamic team. And at the end of October of this year, we had 707 uninsured individuals go through the program. 303 of those have graduated. 239 of those are actively enrolled. And in our disengaged bucket, these are people who go in and out of the program. Next slide. And so from the health and quality standpoint, we really took a look at how our interventions, most of which are not medical or clinical interventions, how they affected quality. So for our enrollees who suffered from diabetes, we have seen a 65% reduction in hemoglobin A1C, and that is a hemoglobin A1C of under 7, and many of these folks started up between 9 and 11. We've seen 47% actually stabilize their blood pressure under 140/90. We've been able to secure 46 homes for our homeless individuals and stabilize housing through multiple interventions for 132 folks that have entered the program who had an housing insecurity. Surprising to us was of the folks enrolled in the program, we've actually been able to secure health insurance. Again, remember, we didn't expand Medicaid through a variety of vehicles, whether it's Social Security, disability insurance, or commercial insurance. As people become more self-sufficient and are able to go back to work, they then have the benefit of commercial insurance. I'm proud of Region 1 to say that we have actually hired a number of the graduates of our program to work within our hospital and health system. We filled medications, we've provided transportation, you can see the metrics there. We've connected to primary care and behavioral health. And again, we know that food insecurity has been an issue and a challenge for many of our enrollees. So along with creating a program for medically tailored meals, we also created a food bank in partnership with our food providers here in the region. Next slide, and I think we'll go to Rick just to give you some finance and utilization data.
Thank you. A key to this is, how do you measure change or impact of the program? And one of the methodologies that we have bought into and agreed is to do a look back. So basically, for every enrollee we have in the program, if we're now 1 month into the program, we'll look back 1 month pre them joining the program. If they've been in our program for a year, we'll look back a year in terms of the cost and utilization statistics. So these are some of the statistics that I see as the financial officer as being very, very important to our program. In the first line, it shows that the cost of the 707 over the time that they've been enrolled pre-enrollment was over $26 million. Post-enrollment, again, measuring the same number of months that were on the front end to the back end, was only $12 million. So in essence, from a total cost perspective, we believe that we've reduced the cost of the uninsured in total cost perspective by 53.6%. The next line, being the financial officer, total cost is a little misleading because of the fixed cost associated with it. But when you look at the variable cost, the cost of nursing, of the supplies, of the meals fixed, that change based upon the volume of patients that you have, the numbers are a little different, but still very significant. Seeing almost a $7 million reduction of our variable cost over the period of enrollment, or a 49% reduction. The thing Susan mentioned was that of payments received. Prior to enrollment, there was no payment from these 707 people. Since they've been enrolled and we were providing one-on-one with them and following them and hand-holding, we've been able to receive over $9 million of appropriate payments due for the services that have been rendered during their time of enrollment. You can then see the next line that we've had a 40% reduction in the emergency department visits during this period. We've cut the number of inpatient admissions by over 56%. We've impacted length of stay by reducing the length of stay by almost a day and a half or 20%, causing a reduction of inpatient days of over 5,000 days, or a 61% reduction of inpatient hospitalization on these enrollees in our program. All of this, and plus the stories of the human interventions, have made me, and from the financial end, be a complete believer and supporter of the program. Next slide.
So I think I'll take this one. So people ask us all the time, what's the secret sauce? How do you work with finance? What makes this relationship as just significant as it is? And the first thing is this idea of creating a common goal. We all want people to achieve their best health. We just speak different languages, so we had an opportunity to pull these languages together. I really fundamentally believe that wherever you sit within an organization, finance can be your best partner, and the earlier you bring them in, the better. We work on aligning our measures of success. Rick and I would go back and forth about what was important. You know, we started with total cost of care, but he really wanted to look at variable cost. We also believe that, you know, it's not an either or strategy, that you can have improvements in health and finance, and we can coexist happily together. And again, thinking about how to change the status quo, just because we've always looked at numbers one way doesn't mean that's the only way to look at them. And at the end of the day, we believe that the magic sauce on top of the secret sauce is engaging the hearts and minds of all involved to create what we see is a sustainable program that's important not just to our enrollees, but also to our community. With that, we'll turn it back over to you, Logan.
Wonderful. Thank you so much, Susan and Rick. It was really wonderful to hear you speak about your work. I know we got a lot of great questions, and we are looking forward to answering as many of those questions as we can during the Q&A. And please, again, if you haven't already asked your question, I encourage you to ask it now at the Q&A icon at the bottom of your screen. Next, we will move on to our moderated CEO dialogue. So I'd like to invite Paul Leone, President and Chief Executive Officer of the Illumination Foundation, and Rebecca Ramsey, Chief Executive Officer of Housecall Providers, to join us for a conversation moderated by Lauren Hardin.
So Paul and Rebecca, thank you so much for taking the time to join us. I've known you for many years, and as clinicians, we've all been part of starting interventions for complex care populations very early, and I've watched you over the last 10, 15 years do that over and over again successfully, all the way up to ending up in roles as CEOs of large organizations serving complex populations. So having spent so many years building the value case in so many different directions, what do you think is the most important lesson you've learned about building the value case?
Sure. I guess I can start. Can you hear me okay?
Yes, we hear you great.
Great. So first of all, I just want to thank everyone for the opportunity to share some lessons learned and appreciate the amazing work around the Better Playbook. The answer to that question for me is through the years that I've been attempting to get funding and support and sustainability for programs, is that you really need both stories and numbers to illustrate your impact. And so this really speaks to Susan's engaging the hearts and minds of your stakeholders. So if done well, the combination of both stories and numbers is really powerful. The stories must be in the voice of the patients and clients. And I've found that video is ideal. Try and show a few different stories that illustrate the breadth of the population that is served, and don't polish them too much. The raw stories can be really, really powerful. And the numbers have to matter to your audience and to your funder. So figure this out early so that the program or the intervention is designed to impact the relevant and important metrics, but also so that you can begin collecting data right away. One of the most recent examples related to numbers or data that I wanted to share is that right now I'm the CEO of a home-based medical practice, and we serve about 1,500 primary care patients that are all either homebound or seriously ill and unable to receive care from a regular brick and mortar setting. We also have palliative care, community-based palliative care, and hospice. And during this pandemic, the homebound population has been the hardest to reach with COVID vaccination. And so we quickly realized that we were in a unique position to serve that population. And so we partnered with the 3 public health agencies or counties in our region, as well as the health plans, and became a primary solution for vaccinating the homebound population who couldn't get out to any of the vaccine events that were happening. And we started collecting that data to really show the impact that we were having. So this is something that obviously we tended to not focus on. Even, I mean, flu vaccines and pneumovax vaccines are also really important, but this was a new opportunity for us to really share with our funders and our payers and our stakeholders how important our programs are. So I wanted to just share that as an example.
I love the creativity of that, Rebecca, and how you've translated that over time. How about for you, Paul? What's your most important lesson?
Yeah, for us, probably the most important lesson has been to have the ability and the wherewithal to change your program if you see something's not working or if there's a new opportunity that presents itself. And about 15 years ago, we started in a motel with a medical respite and a motel model serving the complex populations. And as we navigated our way through the system, I agree totally with Rebecca and Susan. You know, you have to tell that story. And I think that what made us successful in the beginning is we were able to tell the story and why it was so important for not only funders, but for the general public to care about the clients that we're serving. And then, you know, after about 5 or 6 years of collecting data, we realized, okay, I had this multitude of data and it was sitting there. We weren't able to tell the story with the data. And so we ended up connecting with the data scientists, and things started to really progress when we were able to tell the second story. And that was the quadruple aim, that being able to show why, you know, from the fiscal point of view, why it was so important for us to take care of these individuals from the cost perspective. As many of you heard, you know, no money, no mission. You know, if you can't fund something, it kind of hurts us all. So I think having the ability to make changes when the market kind of predicts that it's going to be in. Of course, in California, we have a very large change coming up with CalAIM, and we started changing to accept some of the funding streams about 2 years ago. So I think the ability to look forward and make those changes for the upcoming changes in healthcare systems.
That's so true, Paul. I've learned over time, advocating for these programs, I naturally, as a clinician, could tell the story or highlight and have other people tell their stories. But one of the key factors to really getting strong at building the value case and generating permanent sustainable financing was also being able to translate that into finance language and partner with CFOs and finance leaders so that we were coming together like an integrated team to really address the value case and bringing the strengths of both perspectives to the table. I'm curious how both of you have learned to partner with finance and what the most important lesson you've learned is in relation to telling that financial case.
I think what I've done to partner with finance and CFOs is, again, to your point, try and learn their language, but also help them understand your language. And so if I think about some recent examples, we actually started sending our quarterly newsletter, which has case studies and shares our successes, talks about just regular operational challenges we're having and how we've surmounted them. So I tend to try and find one person or two people in the finance department of whatever organization I'm trying to partner with. And I work on developing rapport with them and definitely understanding just the words to use. So I feel like right now I have sort of a quasi business degree, just because I've had to learn a lot of things on my own or asking finance, can you explain, what is the difference on this P&L, what are these terms mean? Just really inquire so that you're showing interest in what matters to them. And again, I have a master's in public health and a nursing degree. So I did not learn these terms when I was in school, but over the course of, 15, 20 years of being in leadership positions and trying to get programs funded, I really do think they should just be awarding me like a quasi MBA. So, because you just have to have the language. And so the other thing I did recently was I invited somebody from the finance team of this particular organization that we've been working with for a while to go on a ride along with one of our care teams. And you just wouldn't think that would be something they would agree to, but they were super excited. So invite them to an IDT meeting, go on a ride along, invite them to your leadership team meeting, just any way to develop rapport. I think it's great.
I love that. One of the people we interviewed said, people behind my back call me the CF no, but the truth is CF no. I really care about this, but I'm charged with really keeping our organization running. So there's an economic imperative as part of that. If you can help me understand how to bridge that, I want to be part of the solution and the change. Paul, what kind of partnerships have you built with finance and what have you learned from that?
Yeah, in California, we're in the Southern California market, obviously LA. So, we're dealing with the three largest ACOs in the nation, just because they care for so many lives. And I think the one thing that I kind of learned along with Rebecca was that I just assumed that the head of one of the largest ACO companies in the nation had the plan. And then I realized, well, he didn't really know a lot more than I did, and that they're trying to figure out the plan. So it kind of changed my thought process of saying, we have to educate them on what we're seeing out in the field and give them answers to the solutions. And so it's not, I realized too, not going into those meetings trying to sell them, but just present what we're doing. And when we started doing that, we really started to really affect change and looking at what their goals for those millions of lives were. They weren't aligned with our goals. And so, one of the great, I really don't like the New England Patriots, but I have so much respect for them because I heard Bill Belichick one time say, we're successful because I align my goals with the player's goals. And so once we realize, okay, we need to, like, what are they trying to accomplish? And does it align with our goals? And I guess then the last piece is, we're seeing in this transitioning market that size matters. I was talking to people about a great program we did with 150 individuals, and they have 5 million lives, right? So they he kind of walked out of the room going like, oh, that was great. But I realized later that when I spoke to the gentleman years later, he said, yeah, you guys were just so small. I didn't know how we would scale it up. So scale and size are going to really matter, especially in this new transition.
That's so true. I know we could talk with you for a really long time, but it's time to switch to our question and answer. I also want to encourage people, as you have questions, we will continue to answer these after the webinar if we can't get to it. So thank you so much, Rebecca and Paul, for sharing your lesson. Logan.
Wonderful. Thank you so much, Annette. We look forward to continuing these questions here. And I'll invite Rick and Susan to come back on video and audio as well. One question that we've heard from a few folks is thinking about measuring return on investment, or ROI, and how they think about measuring ROI, and how you respond to questions that are asking, what is the ROI? What is the ROI? How you tackle some of those questions when you receive them.
Susan,
Rick, you want to answer that? I was going to say, do you want to answer that?
you take a shot first.
Well, I think Rick will back this up. I mean, we've looked at ROI a lot of different ways. And one of the ways we first looked at it was to say, okay, what money seeded the program and what outcomes did we get for that? And I remember sitting in a meeting with Rick, and he says, this got the greatest return on investment of any program we have at the hospital, right? You've got something like an 800% return for this modest investment. When we started thinking about, well, what were those variable costs and avoided, and then what were the payments that we received? But at the same time, we overlaid that on top of how many people on the Arizona Self-Sufficiency had moved from crisis to stable to self-sufficient. What did those metrics look like? So again, it's not an either or, it was a both and. Rick?
Yeah, and I mean, the neat thing from my perspective was that the financial return was very evident very early in the program. So it wasn't that I was necessarily trying to say make money, but if you can reduce the utilization of your facility in providing care to people that can't pay, it opens it up for the people that can. And that is another opportunity that we've really not talked about, but it is there. And that from the numbers that we showed, hopefully you could see that we reduced ED visits, we reduced length of stay, we reduced the time in the hospital for the whole population. In addition to, we then had the associated cost of it. And then as referred to earlier, we all are human beings, and to then know that the stories of these people's lives change so dramatically while these interventions were going on, that it from my vantage point, it became a win-win for the institution, for society, for the individual patient.
And Rebecca, would you like to jump in as well?
I just wanted to say two quick things. One of the things I've learned in caring for seriously ill, complex, often end-of-life patients is that it's really important to demonstrate not necessarily how your actual patient's costs or utilization have changed through the course of the intervention, because as they're getting sicker, you're going to see them utilize more and get more costly. It's really identifying what would have happened without the program. And in order to do that, you have to have a comparison group that you're looking at in combination with looking at your own population. So that's just one, and it's difficult, and you have to have partners really, that have that kind of methodology, science, skill set. The other thing is, from an ROI perspective, particularly when you're taking care of vulnerable populations, one of the positive outcomes of the programs that I've been honored to lead is that we have stabilized the provider network for a payer. So the providers were having just a really difficult time with resilience and with burnout and with just difficulties related to not feeling like they had enough support for the patients. And so our programs really wrapped around the providers as much as they did around the patients. And for a payer, they really need to have a stable provider network to care for their patients. So that's just another example of an ROI sort of component that was really important.
3 fast insights from the interview. So definitely looking at the 360-degree impact of ROI, like Rebecca was saying. So not only in your own organization, but across the community. And secondarily, learning how to subtly look at return on investment. So what's the difference between fixed and variable costs, and how are you shifting that needle? Third, how efficiently are you delivering what you're delivering, and thinking about different roles and different people being part of the team, like peers and community health workers, who needs to be doing what for efficiency. And then fourth, really understanding when people bring up regression to the mean, starting to look at for how many previous years has this person been a high utilizer and a high cost patient, and tiering out the way you look at outcomes based on the length of time they have been high cost, high utilization.
Wonderful. Thank you all so much. And we've received a lot of questions asking for more detail about some of the care models of the programs that we've mentioned. And I'll note that there's been a number of published resources on each. And so we will work to collect some of those and share those in a follow-up email with you all, which I think will speak to a number of the questions that were raised. And then just in the last minute, a question, kind of what do you see as the future of financing care and the value case for populations with complex needs? So if there's 1 or 2 people that would like to tackle that in 30 seconds or less.
I just want to throw out their workforce. I think workforce is going to be our biggest challenge moving forward, and the nonprofits, the hospitals, the companies that can really strategize and use licenses at the top of their levels are going to probably do really well, and others are going to be struggling with trying to find people to deliver healthcare.
I think that funders are increasingly, and financing is increasingly looking at the ability to close healthcare disparities and social justice, social equity. And so we need to be really clear about what our intention is and how we can impact those really important metrics.
I think unexpected partnerships, new collaborations coming together across community, including people we haven't necessarily thought of in healthcare delivery, like criminal justice, sheriffs, police, judges, as well as traditional players. And then really a move towards total cost of care and looking at that collaboratively across sectors to really start to invest in really changing root causes for the population. That's my hope.
Wonderful. Thank you all so much. I feel like we could go on and continue the conversation for many hours. Unfortunately, our time is up. And so I'll just quickly note that We encourage everyone to share your successes, your work, and your questions on the playbook. You can browse the playbook for additional resources that are related to evidence-based and promising practices for populations with complex needs, and submit resources to the Better Care Playbook. And next slide. Finally, we just ask that you fill out the evaluation survey that will show up on your screen at the end of this webinar. We really value your feedback to help us develop and share content on the playbook that meets your needs. And I want to close today by thanking all of our presenters who shared such valuable insights with us today, especially to the National Center for Complex Health and Social Needs for partnering with us to really highlight these wonderful resources. Also to the 7 Foundation Collaborative for making this webinar possible. And then all of the participants who joined us on the webinar today and shared your great questions. We'll plan to follow up with some additional resources within the next few days. Thank you all so much, and have a wonderful day.